Today, we will focus on crisis intervention and suicide prevention. I'd like to take a moment of pause to reflect on our own lived experiences and recognize the fact that many of us are drawn to this profession, having experienced the death of a loved one by suicide or the loss of a loved one due to a fatal overdose. As such, I think that it's an important opportunity to take the time to recognize that this information can evoke highly emotional responses. Yet, this is a great opportunity for us to look at how to engage in self care, social justice, and advocacy for the profession. With that being said, I'm going to move forward today and talk a little bit about statistics related to suicide and addiction. We're going to speak about crisis, trauma, and emergency. We're going to look further at real versus perceived threats, and then move into implications for mental health professionals and start to explore practical applications for interventions. Suicide is the 10th leading cause of death among all Americans, but this is the third leading cause of death of Americans aged 10 through 14. And then suicide is also the second leading cause of death for Americans aged 15 through 34. Recent research is showing us that individuals that are of older ages, 60 years and older, are at increased risk for suicide. There is also an interconnected relationship between suicide, depression, and substance use disorders that we simply cannot ignore. So, more than 90% of individuals who die by suicide suffer from depression, have a substance use disorder, or both. So, many who experience depression engage in substance use as a form of maladaptive coping. And in fact, substance use can exacerbate the severity and the duration of depressive episodes. And then lastly, about 40% of individuals seeking treatment for substance use disorders report some type of history of suicide attempt. So as you can see, this is a highly important topic of conversation. So let's jump in and get started. First, I'm going to start by defining a crisis. A crisis is defined as the perception or experiencing of an event or situation as an intolerable difficulty that exceeds the resources and coping mechanisms of the person. And unless the person gains relief, the crisis has the potential to cause severe affective, cognitive, and behavioral malfunctions. There are various types of crises to identify, and also we must look at the impact of culture on each type of crisis as well. There's also a variety of contexts and precipitating events that may give rise to a crisis. So, four commonly recognized classifications of crises are developmental, situational, existential, and systemic. The defining aspects of each type of crises are identified here. Let's talk about developmental crises first. We see that this happens when events in the normal flow of human growth are disrupted by a dramatic shift that precipitates a change in the way the person may function. This could include the birth of a child, a retirement, a graduation, career changes. So we're looking at significant life events here that can include the family. With regard to situational crises, these emerge with the event of an unexpected event, and it lies outside of the realm of normal functioning in individuals that they neither anticipate nor have a way of controlling the situational crisis. So these crises might include something like a car accident, a sexual assault, a severe illness, and we can see the profound implications of this, especially if we think about the COVID-19 pandemic and everything that came along with that, job loss. So those are some examples of situational crises. Existential crises occur when an individual becomes aware that an important intrapersonal aspect of their lives may never be fulfilled. This, in turn, has an impact on one's sense of self-purpose, self-worth, meaning, and just overall purpose. An example here includes a failure to fulfill a lifelong dream into a personal conflict about lack of meaning in one's own life, or the realization that one has not formed significant relationships throughout their lifetime. Existential work deals a lot with death and dying and helping people to really explore the lifespan development and death. Systemic crises occur when an identifiable event ripples out into a large segment of the population and the environment and has a psychological impact on not only the immediate survivors, but on people throughout the world. So here we can see an example of natural disasters, terrorist attacks, school shootings, and we can see the long-term effects of how these crises have impacted the safety, health, and well-being of those impacted. Furthermore, when we look at a crisis and culture, crisis intervention is often influenced by cultural elements. The four types of crises outlined earlier can serve as a context for examining the impact of culture on crisis situations. So, for developmental crises frequently involving a cultural issue, for example, pregnancy out of wedlock may precipitate a crisis in cultures where pregnancy outside of marriage is unacceptable or immoral according to one's religious beliefs. However, that same situation may be tolerated or even widely accepted in other cultures. Unlike developmental crises, situational crises are less likely to be tied to culture. There are few cultures in which sexual assault, mugging, or automobile accidents are not necessarily considered a crisis. Similar to developmental crises, existential crises may occur across cultures. Death is a primary example because meaning and occurrence of death varies according to culture, religious, and spiritual beliefs. Finally, systemic crises, like situational crises, tend to be universal. These are more large-scale disasters, such as hurricanes or earthquakes, that can always be considered a crisis regardless of where that event occurs because it has such an open, long-lasting effect on potentially the world. So what do we need to know? Look at these three terms: emergency, crisis, and trauma. Psychological emergency, crisis, and trauma are routinely used to refer to crisis. However, this leads to a misconception about the crisis experience. One such misconception is that the crisis experience unfolds in a linear progression that begins with an emergency, leading to a crisis, and then results in a trauma. However, individuals may experience an emergency but not be in a crisis. Individuals may experience an emergency but not have a traumatic experience. So this information depicts the relationship of the psychological emergency, crisis, and trauma characteristic salient to each of these three experiences, and they may overlap and they may be interconnected. And yet these experiences described as a psychological emergency, crisis, and trauma truly have unique features that distinguish them separately from one another. When we look at the connection and start to pull these apart, we can explore addiction, stress, and trauma. We see various traits among crisis, trauma, and addiction. So the traits of people in crisis are likely to present as being overwhelmed, impaired in their ability to cope, or impaired in their problem-solving strategies. These individuals may be susceptible to long-term emotional, behavioral, and cognitive problems, and they may also be capable of bouncing back as well. As we look at resiliency, to understand it is not an innate characteristic for individuals. Resiliency is something that can be built upon, that can be expanded upon, but only with appropriate support and coping strategies and the ability to self-regulate. As we look at trauma, trauma occurs when an individual experiences or perceives an enormous sense of helplessness in the physical threat that leads to the interruption of normal development. Traits of people in trauma include the demonstration of evidence that permanent change exists in one's belief about the world. So we know developmentally, we all develop the schema around ourselves, others, and our worldview very early on in development. And this continues to grow and evolve throughout our lifespan based on a traumatic event, crisis, or emergency. This could have profound implications for how one sees the world, ultimately making deep embedded changes in their view, their perception, their attitudes, beliefs, and biases. Next, we look at individuals who experience trauma as having an inability to form healthy relationships. This may be a result of attachment theory and this disorganized sense of how do we develop relationships, this fear of allowing people to get too close, and I might abandon you before you abandon me. And can we see this manifest very differently based on one's unique experience, their development, and ultimately looking at their attachment history? And we can also see a decreased ability to understand complex emotions. Something that's very interesting about addiction, stress, and trauma is that I've often seen individuals seek treatment and they're either feeling really great or maybe they're feeling really bad. Maybe they're feeling at one extreme very happy or at the opposite extreme very sad. Maybe they're very happy or maybe they're very depressed. They're happy or they're angry. There's really no in between. And so that ability to get in touch with feelings that are lacking or that are very minimal, this is going to be a very important intervention that you can use. One of the interventions that you may choose to use is you can go to a home improvement store and you can get paint chips. And there's lots and lots and lots of colors of paint chips whenever you go to these stores. And you can use these on a spectrum. And individuals might not be able to identify with how they feel, but they may be able to associate with a color and how that makes them feel. This then helps the connection between one side of the continuum to the other side of the continuum, as well as helping make that connection between the left hemisphere and the right hemisphere of the brain so that people can start to move in a direction to identify feelings, to look at their beliefs, to start to engage in behavioral changes. So I think that that's kind of a neat technique that you can use with your clients. Also, we have to look at the idea of individuals who have had trauma. They may experience flashbacks, nightmares, intense emotions, and this is not abnormal. In fact, this is a sign of healing. If people are experiencing nightmares and flashbacks, their body is starting to release this information, noting that they are capable of starting to handle pieces of this. I think it's important for us to note that this is in fact a sign of recovery, and it's important to start to explore the trauma and be able to move forward in this recovery process. The connection with addiction is, of course, as we know, these symptoms of crisis and trauma can highly exacerbate one's ability to engage in maladaptive or high-risk behaviors. So these emotional triggers can lead to craving, which can result in one's ritual of picking up a mood-altering substance, using that substance, and ultimately feeling a sense of shame and guilt and or depression, which just kind of keeps them stuck in this cycle of addiction. These interconnected pieces are at times difficult to see when you're working with individuals, but I think conceptually it's important to look at these characteristics to see how these characteristics might be triggering an event, for an emotional experience, for a substance use experience, and to find ways to help self-regulate, develop coping skills, and to break the cycle. When we look at suicide prevention, we're going to be assessing an individual's intent around suicidality or homicidality as an example. So people might have a fleeting suicidal ideation. Otherwise, people may have a more active suicidal ideation. Regardless, we're always going to engage in assessment of that risk. We're going to look at one's intent, the means that they have access to, any gestures that they may be making, and if they do, in fact, have a plan. So as we're exploring this with individuals, we can begin to see how active the suicidality may or may not be, and then start to move into our plan of action, which may include keeping them safe when they don't feel safe, which may include fighting their addiction when they're not able to fight it, which may include looking at a traumatic event and helping them to keep safe, despite how these events might feel very overwhelming for them and feel as though they feel very unsafe. We're going to have some difficult calls to make in the field. Do not forget that you have access to supervision, consultation, and always engage in self-care to avoid compassion fatigue, vicarious trauma, and ultimately burnout. We need to be able to take care of ourselves to then take care of others. We need to be able to listen to our third ear to things that maybe aren't being said and to start to assess the means, the plan, and the gestures. In the event that someone is unable to stay safe or we fear for their own safety or well-being, we would move into a 302 process potentially. I'm not going to get into the depths of that because it does get very complicated, and every agency that you could potentially work with is going to have their own way of addressing suicide prevention, crisis intervention, crisis management, and protocol. So please make sure that you're working with individuals in the field to really understand whatever your agency protocol is. But I do want to stress that when you are working with an individual who presents with suicidal ideation, we never ever leave them alone. So as much as I'm telling you to seek supervision and consultation, I'm also going to stress the idea that you do not get up and leave the room to go and find a supervisor and leave that individual who is expressing suicidality alone. You can either take that person with you, or you can call the supervisor and ask them to come to you. You can ask other people to work in tandem with you. So please don't ever, ever leave an individual alone if you're fearing for their safety. I also want to stress that we cannot uncover trauma and traumatic memories for those who are still in danger. If an individual is living in a recovery environment where there's violence, abuse, where there's substance use going on, it's going to be extremely difficult to uncover traumatic memories because of that imminent danger. If someone is experiencing violence or engaging in self-harm, we need to find ways to resolve that imminent danger in order to uncover trauma memories. So this is very much a linear process. We cannot do the work if someone is still in imminent danger. There are aspects of the work that we can do when someone is in imminent danger, and that can start the process of gaining support, providing them with resources and education. But to do the depth of trauma work for individuals who are in imminent danger, that's not realistic, and ultimately it's not ethical. As such, we start to look again at the idea of real versus perceived threat. So is this imminent danger real? There's a huge difference between I am safe and I feel safe. If we look at people who are engaged in a recovery environment that is very unhealthy, maybe their basic needs are not even being met, this could in fact be normal for them. So again, we're going to have to tap into our own attitudes, beliefs, and biases around this. We're going to have to be curious and explore what is happening in one's recovery environment as an example, because although it might not be meeting their basic needs, they may actually feel safe. But does that mean that they are safe? Those are the types of questions that we have to explore with the individual to help them discern whether they are feeling safe, whether they are safe, and this concept of real versus perceived threat. So if an outside danger exists, that is the time for a behavioral intervention in terms to resolve that threat. If an inside danger exists, this is the inability of one to cope, to self-regulate, to engage in harm reduction behaviors. So we're going to need to help individuals to find ways and means to self-regulate. Look at anxiety management skills and start to engage in some cognitive restructuring to evaluate their potential irrational beliefs and how that's influencing their behaviors. For the counselor, when we work with individuals in crisis, again, it can be very difficult to stick and stay in those relationships. We absorb the impact of other people's trauma, and we're called to be ethically obligated to be in a position to care for others when maybe they're unable to care for themselves. That can be quite a task. That can be extremely stressful, and it can also be very frustrating. You may have an individual that you've been working with for months, if not years, that stays in a relationship that can be unhealthy for them, that stays in an environment that's unhealthy for them, and you wonder, when will they start to make the change? And we understand that this could be a life or death situation for them. It's important, again, for us to get that self-care. We need to seek supervision and consultation when appropriate. We need to be taking care of ourselves to stay on point and to be able to help that person that we are working with. We need to be able to manage our own stuff. We need to know when to sit our own stuff on a shelf and come back to it when the time's appropriate, or maybe to deal with it in supervision. We need to recognize that our therapeutic alliance is the foundation of our relationship, and building trust and being with that individual is going to be of the utmost importance. Working in a crisis environment and doing suicide prevention with individuals who present with substance use disorders, a history of trauma, or co-occurring conditions really calls upon us to have poise, engage in self-care, and be able to pivot and adapt, to be creative, to always be seeking supervision and consultation, to remain non-judgmental, to look to ways to instill hope that recovery is possible and that change is possible, and always creating and sustaining a safe holding place for individuals to come and explore their options. For the survivor, we're really going to be looking to resolve the imminent from the real danger. We're going to help them distinguish versus that real versus perceived threat. We're going to help them develop regulation, relaxation, and grounding skills. Also, we're going to help them demonstrate the ability to self-regulate. So in those moments where they start to have this emotional response in session, we're going to revert back to them and say, what have you learned? What skills can you use right now? I'm noticing you're having a abreaction to this, and I'm noticing the fact that you're being triggered. What skills do you have to implement right now to help you engage in self-regulation? Again, we want to empower the client to be able to make change and to pull upon the skills that they've already learned. Also, we are going to then allow them the ability to demonstrate that self-regulation, self-rescue, and ultimately commit to address the trauma. Trauma resolution, safety, and stabilization interventions. We're going to be talking about this in future lectures, but there are many ways that we can engage in trauma resolution, help people move through the trauma recovery process, aid with substance use disorders and co-occurring conditions. By creating a safe place, we can use imagery, visualization, art, and self-efficacy. These can be great means that allow the individual to show their internal locus of control, although that individual is feeling triggered, that they're feeling anxious, although they feel like they are in a threat of safety. What can you do with your imagery to help you show that you can, in fact, control your thoughts, feelings, and emotions? Icon in an envelope. We're going to talk more about this, but this could be a really fantastic way to show individuals to write a letter to themselves. Maybe they're not ready to share with you an event or how they're handling that, but they can write a letter and we can work collaboratively with them to hold that letter. And if they can give it to you, they're really engaging in a behavior of handing that over to you, demonstrating that power exchange, that collaboration, and then you can hang on to that envelope until they're ready to explore that further. Could this be a sign, a symptom of something that has meaning and power for that individual, for the recovery process, that maybe they're asking you to hang on to that? And in those times when they're really stressed, we can talk about, what is it that you need? What does this mean to you? And how can we bring this into the equation? There's also thought field therapy by Robert Callahan. Some other techniques we'll talk about more later are going to be progressive muscle relaxation, diaphragmatic breathing, grounding, the polyvagal theory, EMDR. These are all excellent interventions. And again, we're going to talk about this more in future lectures. Finally, I'd like to close with the fact that we know that the vast majority of individuals have experienced trauma, have also experienced addiction. They have experienced co-occurring conditions. They are likely to experience depressive episodes, symptoms of anxiety, and in feeling this lack of safety in recovery. Judith Herman said it best, dating back to 1979, the message still remains true that the steps of recovery, although they are not linear, we look to establish safety, that we must help the individual have remembrance and mourning and work through that loss. And then when we work with individuals to help them establish reconnection and foster growth and change in a recovery process. Thank you so much for your time, and I will see you in future lectures.